Hi, everyone. I'm Julius Torelli, and this is Off the Cuff, EviCore Healthcare's podcast, where we talk everything utilization management, the good, the bad, and the ugly, and what EviCore is doing about it. I'm wearing a collared shirt for the first time since, I don't know when. It's been a while. I also learned that shaving is a bit like riding a bicycle this morning. And my face kind of appreciates that for sure. We have a very exciting episode today with Lauren Kortmeyer and Aaron Hackman from the University of Colorado Department of Radiology. Aaron, would start with you. Maybe you could talk a little bit about the history. One of the things that we find here, at EviCore, and we spoke about this in previous episodes, is the administrative burden and the challenges with pre-authorization. And I wonder if, one of the things I talk to a lot of provider and provider groups, and again, when we look at the pre-authorization process, it is a challenge, and you guys do it particularly well. You've clearly invested in your people. You've invested in the systems and such, and it was a sort of an amazing team that you've put together, and I was very impressed. So I wonder if you could maybe tell us a little bit about that history, tell us a little bit about that, again, making that investment. It had to be an obvious conscious effort to do that, and maybe how that all came about.
Sure. So my background is radiology. So I was a X-ray tech, CT tech, manager of radiology, director of radiology. So everything has always been on the clinical side of things. There was a position that came up, and I was offered at the University of Colorado Hospital before it being UC Health, that was they called it reimbursement specialist, and it sounded interesting to me. So I accepted it. I had a directive from the radiologist and director of radiology there at the time was find things that's broken and fix it. Okay, that's pretty easy. As I started working through these pieces, I realized that on the scheduling and authorization side, there was a disconnect between what was happening. So, for instance, we were kicking back a lot of what we call peer-to-peer. So, when we submit for authorizations, if all the information isn't there, as you guys know, to establish medical necessity, everything gets kicked back to the clinic or the provider basically to fix the problem. And so we would always be hearing these words about, they have to do a peer-to-peer, they have to do a peer-to-peer, whatever. And as I investigated these pieces, it had nothing to do with a doc most of the time. So why are we throwing this stuff back to a doc to figure out how to fix it or to do this quote unquote peer-to-peer? So I started registering myself on the portals as a referral specialist for the university hospital, and started just digging into the portals, trying to understand how all this stuff worked and what was happening. So I selectively started grabbing pending or peer-to-peer referral requests or authorization requests, and started making calls. And I'd talk to the nurses on the other side of the table with the insurance providers or with the authorizing entities, and found out it's no real big trick to figure out what's missing in the submission for the authorization. Provide the information, get an authorization. It didn't have to go to a doctor. So most of the time, and I'm going to call that like the 80% rule. I could fix 80% of this stuff without involving a clinician or anything like that. So that's where the guidelines came into play. So all the major players have some level of guidelines that are out there, and in theory are intended for providers to understand how to get an authorization or what it requires to meet to get an authorization. I think the disconnect for that is that nobody uses them. I mean, these providers order their stuff because they think it's necessary, and the documentation isn't necessarily meeting the sometimes pretty specific steps that are required to get the authorization in place. That was kind of the beginning. I was the person that was making the calls, trying to push through pending or peer-to-peer authorizations.
So you were the only person at the time?
I was the only person. Yeah.
Okay.
And,
Okay. And how many people do you have now, you think, on your team?
probably over 50.
Wow.
I would say.
So
Something
again,
like
I
that.
think, yeah. So again, that's an incredible investment, but clearly someone, in the whatever finance office, the accounting office at University of Colorado must believe that, this team, which again is we certainly understand that that's an expense, but that someone must believe there's a return on that investment.
Yes. Yeah. It's interesting because it's hard to actually get good line item data on what's being denied. So that was a piece that I did as well in the very beginning, was spent a lot of time with a report writer and tried to pull radiology denials on the back end. I was able to get my report such that it would capture denial reasons, remit, how the EOB comes back and denies for things. You see a lot of no auth, quote unquote, denials, but the truth is, if you start doing a root cause analysis on what your common denominators are on each of these denials, you can start figuring that out. So I was using that to go, okay, what can I do up front to change what my denial is on the back? Because we just want to get paid. And we were finding that with our processes, as we monitored them over about a year's worth of time, it was clearly evident that when we were doing what we were doing, we were saving around $165,000 a week in denials. So it was real money.
Yeah. So it's interesting because you had the same sort of enlightening moment that we have at EviCore, and that is, the last thing we want is to get to that peer-to-peer sort of process, because it's time consuming on everyone's. It's expensive for everyone. It's expensive for EviCore, but it's certainly expensive for the provider, and that's a time for the provider and such. And so we have worked very hard trying to do exactly what it is that you were doing from your end, and that is trying to get that information, better information up front. The last thing we want is to do a peer-to-peer, and the doctor says to us, this is a no-brainer. I can't understand why this was denied. And he gives us a perfectly acceptable reason to do the test. We approve it. And the whole problem there was just that we didn't have that information initially. Had we had it, then it would have been authorized, immediately. So Lauren, let me ask you, one of the things Aaron was getting to was about the EviCore guidelines. So, we catch a little bit of flack for our guidelines because they're organized in a fashion that's different from generally what's in the industry. So in the industry, whether it's the RBM industry or the health plan industry, coverage policies, criteria generally written, they're procedurally based, right? They're CPT based. So in other words, it'll say a CT scan is good for, and there's just a list of things that a CT scan is good for. CT scan is good to image the head, for headaches or what have you. It's good for abdominal pain. But yet we know that there's really so much more. So our guidelines are set up more conditionally based rather than procedurally based. And we think that's of value because it's not just about, that the fact that a CT scan may be good for a headache, or it may be good for abdominal pain, but there's a lot of other tests that may actually be better.
We love the EviCore guidelines. They are our gold standard, our go-to for everything. And they're truly all-inclusive. I mean, if we use another set of guidelines, they don't have, for example, appendiceal adenocarcinoma. That doesn't exist on some of these other guidelines. Whereas if you type that into the EviCore guidelines, it takes you exactly where you need to go. And from the clinic review side, we pull up the guidelines on every single case we work, and more times than not, they are the EviCore guidelines, just because they are all inclusive. They tell us exactly what we need to look for. If the provider hasn't ordered an x-ray on a knee, well, we're going to ask for the x-ray before we go any further. They are our Bible. All of the nurses have the EviCore guidelines up, and that is the majority of my 10-hour shift is spent reviewing the EviCore guidelines. They have everything we need for what we're looking for in, clinical documentation.
We play the role of a liaison between the providers that are ordering this stuff, and they don't have time to be messing with this, and getting the authorization in place. We provide that information to them from the guidelines. We'll do print screens of it, send it to them, so here's what we're dealing with, help me navigate it, that kind of thing. I will tell you that I very frequently send print screens of EviCore guidelines to my docs for other entities, because it spells out what we're dealing with, even though it's for another entity to get an authorization. And we can have our dialogue on what we need to get in place, then go back and deal with it with the other RMB or organization that we're doing. And I don't know if you do that, Lauren, as well, but I suspect
absolutely. Our providers understand the EviCore guidelines. They're clear, concise, to the point. Some of the other payer guidelines are paragraphs long, and we can't ever expect our provider to, read that or understand it. So I very often do use EviCore guidelines for other entities.
EviCore has been a great partner for us, and listens to what our feedback is to try to help make some of the processes better. And I mean, the guidelines evolve, and it's because it's a learning process. And I think that just having the input on both sides, that I think is very candid, helps everybody to not waste any resources and time going with that. So the other entities, they're not that at all. Well, the one that I'm thinking of is a large entity. They're actually resistant to anything. They very much set on their diagnosis code driven processes that don't work, and they don't want to hear that they don't work. And it's interesting.
And we know it's an administrative burden, which is where all this technology is headed to help with that. But we don't want to be obstructionist. We really want to make sure that if the test is appropriate, then we want to make sure that the patient gets everything that they need, but we don't want them having to get more than they need, and we certainly don't want to put up obstructions or delay things. So we appreciate the input and the partnership.
Yeah, exactly. I know, and it's very much appreciated on our end as well.
I was impressed when I spoke with you. I've spoken to you many times over the years, but again, I think the team you've put together, the process you put together, the investment you all have made, and the fact that you feel that was worthwhile, that there is a return on that investment, I think is really important and great to see and great to hear. So certainly appreciate both of you agreeing to come on and talk about that, and thank you.
Thank you so much for having us.
Yeah, absolutely.
Yep, appreciate it.